Hi, Matthew Holt, another THCB Spotlight here, and I'm visiting with Natalie Schneider. Natalie is the CEO of Thought Health, which is a company which is in the child and adolescent mental health field. There are a number of other companies in this space. You probably run into Brightline and Little Otters and Beamy and a few of the others. But as anybody who has kids knows, and especially if you, I was actually Natalie was on a school tour last night. Counseling mental health and kid and teen mental health has become a really, really big deal in recent years, especially since the pandemic. So why don't we start off, Natalie? Tell me a little bit. You've been doing this. You've been elsewhere in the world of health tech and health insurance previously, but you've been doing this company for now, what, 3 years now, I think, Leaf, Fort Health. So tell me a
Yeah.
bit about why you decided this was the thing to go into and what your approach is.
Like yourself, I'm a parent first and also a sort of health advocate, second, third, and fourth. And between my partner and I, we have 5 kids. So not only have we seen sort of various aspects of mental health care unfold around the dining room table, we're also in a community where friends and family are telling us it's 15 weeks to get in to see a therapist or a psychiatrist. Even when I get in, they're not accepting my insurance. No one's coordinating with my pediatrician. So it quickly became evident that this was a space that needed additional attention. So that's sort of like piqued my interest. And then I started speaking to folks sort of in the pediatric space, and I was on a walk with a lovely friend of mine who's a pediatrician, and she's my age, so very young, Matthew.
Of
And
course, just in high school, yes.
she said, she said, I'm quitting. And she said, Natalie, most of the kids that come in have a behavioral health condition. And I have 15 minutes to diagnose these kids and in some cases prescribe. And so I'm just not, this isn't what I trained to do. I was trained as a pediatrician. And as I started to look into it, she was absolutely correct. Mental health is now the most common presenting condition in a pediatrician's office. Um, Back in 2019, in fact, mental health disorders surpassed physical conditions as the most common reason kids have an impairment. And yet, most pediatricians didn't complete child or adolescent psychiatry rotations. So we're sort of putting them in this position of being frontline behavioral health providers without the requisite training or support. So that was really the birth of Fort Health is we need to be in the space and what's the right way to do it. And the headline is the right way to do it is in partnership with pediatricians.
Okay, so what is the approach that you then take? So you talk about partnership with pediatricians, but I mean, obviously there are kids who come to mental health from a variety of places. There's a lot of self-referral going on, as you know, and there are a lot of companies now, both in the sort of standard adult mental health virtual space, but also in the pediatric space, who are either going via plans or employers or somehow else trying to get there. So, what is your strategy for attracting patients, kids, and then what do you do to be in conjunction with the pediatricians?
So if we start with the front of the funnel,
Yep.
it's 1 in 5 kids has a behavioral health condition that needs treatment. Of those children that get
I
diagnosed,
live in Marin County. It's about one in one. But go on.
yeah, it's, consistent and persistent issue. And of the kids that are diagnosed, about 75% are diagnosed by the primary care provider. So this is the widest, biggest front door. There are other channels, and about, 10% get treatment from a school counselor or school psychologist, etc. But most kids see their pediatrician every year, 93%. Most kids getting diagnosed are getting diagnosed by a pediatrician. And pediatricians are trying to keep up and play that role. About 85% of psychotropics, which are medications that affect our mood and our behavior, and that are being prescribed by pediatricians. right? So that's really the state we're in. And if we play to where the puck will be and we sort of look at the crystal ball, we already know there's an issue with supply of pediatricians. And I'm sure, Matthew, you read the same reports that I did, that last year about 30% of pediatrician residency spots went unfilled. So fewer and fewer people going into it, many more pediatricians retiring. So you've got these very valuable pediatricians that are spending more and more of their time on mental health. So our model is to be a wraparound for those pediatricians and deliver not only integrated care, but also collaborative care, which is a very different clinical model.
Okay, say a bit more about what that means, right? So now, so you're getting referrals from pediatricians, fair enough. How do they know about you? And then what do you do and what do they do? Do they still do the prescribing? What services do you offer? Just go down a bit about what is the actual experience like for a patient if they get referred by their pediatrician to Ford Health. What happens next?
Yeah. So the pediatrician will refer to us using whatever workflow they use today. So that could be an e-fax, a call, it could be using a portal, whatever they do today. That's the most important thing, not to upset their workflow. Once we get that referral, we do outreach to the family. We get them enrolled in care. That's either therapy and psychiatry, which is what most people are familiar with, or it's a model called collaborative care, which is probably one of the most well-studied mental health, interventions of the last decade. Over 90 randomized controlled trials to support. It's twice as good as usual care for anxiety, depression, ADHD, etc. So it's one of those two. And then what makes the model unique and why pediatricians really like this model is that it's closed loop. We go back to that pediatrician. We say we've either got your kiddo in care or we did outreach to the family, couldn't reach them. Do you have a different contact number? And we provide those treatment updates and discharge summaries. And in some cases, that's dropped directly onto the patient record. What they're telling us is that is differentiated and that is incredibly helpful because today, as you know, if I walked into a pediatrician's office with one of my kids and they're diagnosed with anxiety, I'd be given a sheet of paper. And as the parent, I'm quarterbacking that care and I'm calling various providers to try to get that person in. So we take all of that administrative uh, lifting of both the pediatrician and the parent.
So now you've got the patient, and you referred back either way, and you've tracked down the family, or you've done whatever you've done to get them. What happens next? What are the services you're actually delivering directly to the patient?
So the services that are delivered is evidence-based, measurement-based, um, therapeutic interventions, so therapy. And while that sounds like just a lot of words, it is shocking to note that only 20% of behavioral health care today is evidence-based and measurement-based, which means, in layman's terms, we're saying objectively, we don't have the data to determine when that child is ready to be discharged. So it is evidence-based, measurement-based care. We have a partnership with the Child Mind Institute, who's a nonprofit in this area, that's developed training exclusively for our providers. And we track that child throughout their course of care, provide the pediatrician updates, and when that child is ready to be discharged, we do that with the benefit of data. So that's with therapy and psychiatry. With collaborative care, that is a separate set of CPT codes. That model is very well established in the adult population. It is much more novel in the child population. And with collaborative care, it is much higher frequency, much shorter interventions. So it's not sitting down for 55 minutes, which, kids are not very good at. And plus, if your therapy appointment is Tuesday, 3 p.m., what's the likelihood you're going to remember what happened last Friday and last Wednesday, etc. So that's why I really love collaborative care because they are behavioral health interventions that happen much more frequently. And in that model, the pediatrician stays the prescriber. So we become sort of the behavioral health intel inside. Uh, the psychiatrist is on our staff. The behavioral health care manager is on our staff. But we maintain the integrity of that relationship between the pediatrician and the patient, and the pediatrician stays the prescriber.
So in terms of the collaborative care, just to give me a sense, for the patients you're treating, the kids you're treating, how many go into which the more traditional model, how many go into collaborative care? Then in terms of collaborative care, I mean, how does that actually work? So now I've got to get my kid in front of a video call 3 times a week, twice a week. What am I doing what's different than the once a week or twice a month or whatever, talking to or once a month, I would often it's talking to a psychiatrist or a therapist that currently happens, or they might get at school or whatever.
Yeah. Um, so in terms of nationally, what the mix is, I'm not sure because there are not very many companies doing child and adolescent collaborative care. But for Fort Health, it's probably sort of four-fifths, one-fifth, because we just launched collaborative care last year. There's been really good uptake. Pediatricians are really excited about it. Parents are really excited about it. And one of the nuances that's really important from an affordability perspective is there's one copay a month for collaborative care. And that doesn't seem like a big deal, but if you are a mom that came to us last week that has 3 kids that need therapy, um, and if each of those 3 kids is doing therapy once a week, you're looking at 4, 8, 12 copays
Right.
potentially in a month. And that can really add up even though we take insurance. So collaborative care is much more affordable. For the parent, it's much more clinically effective, etc. And in terms of how it works, it's right out the gate, it's much more intensive treatments, so much higher frequency, but still short duration. And sort of second month, third month, etc., it starts to subside. It's very much driven by the child's needs, as opposed to therapy today, as you know. Uh, the fact that every Thursday, let's say at 3 o'clock, I'm seeing my therapist, and that may not be when I most need therapy. I may not have a perfect recollection of what's happened over the past week, etc. So I think especially for kids, I'm really excited about the potential of this model. It's well researched. It's well supported by the literature. Um, and I know payers are very excited about it as well because it integrates physical health and mental health. And the research, Milliman and those sorts of reports suggest that you're going to get a 9 to 17% savings on your claims cost when you start to uh, make that integration.
So speaking as a parent who went through this process with a different organization, one of the things that I didn't enjoy much and don't think was very helpful was that the fact that there was a lot of in the early sessions, as with me and the kid in front of the psychologist and with the therapist there was a lot of instruction to me, which I felt was kind of a waste of time. I wanted to see more focus on the kid, but there are obviously things that a parent is supposed to know about how to manage behavioral issues and this, that, and the other. Um, and I assume that probably gets replicated by not so much pediatricians, but therapists across the board, across America, are all telling parents stuff that they could probably learn in different ways. So how have you approached that?
That is, I'm so glad you raised that because number one, the research and literature is so clear that if you educate the parent, your clinical outcomes are so much better, which makes sense because we're with our kids most of the time. And but you're right, spending the first 2 to 3 sessions on something that could be self-taught is a waste of time. And we learned this pretty quickly. So we developed a parent education course. It's 10 lessons. And it's based loosely off a lot of the concepts. One of our partners, Dr. Harold Kopowitz, includes in his book, Scaffold Parenting. But as soon as a family is referred to us, that course goes out to the parent, and they can choose to listen to it on the way to soccer practice or whatever it is, and their companion guides and worksheets, etc. So they're being very, very efficient with that time with the therapist or psychologist.
All right, that's great. Do you think that I know we've touched on this a little bit before in the interview, but do you think there's a eventual companion course for the kids as well, or do you think that, as you said, you're hesitant to want to do technology for the kids, and whether that's a good use of your engineering dollars? Although I think they're all free now, aren't they, with AI, with DeepSeek, but who knows? But I mean, do you think there's an eventual sort of companion course for kids as well, and there's the sort of potentially AI or other forms of technology play into that?
Yeah, that's something we piloting right now to figure out how do you hit the right balance. We know that with apps, 97% of them are discarded within 2 weeks. So that might not be the right solution. But how do you reinforce that they are making progress, that there's momentum, and sort of reinforce those learnings? I definitely think there is room for that.
Give me a sense of where you think you are. You guys are relatively new as a business. I know you raised some money a couple of years back, and then had another round just more recently back in the last year. Give me a sense of where you are in terms of where you are, which states you're available, where you're accessible, how many families have gone through the program or are going through the program. Just give me a sense of sort of that part, and then how big an organization you are.
So our first full year of operations was in 2023, and we've served about 2,500 families in that time, and started with New Jersey, Pennsylvania, New York. We've just expanded into Texas and Illinois. We are insurance-based, so that is at the core of our mission is we want to expand access to quality care. So our philosophy is we will try to get to 100% covered lives, or as close to that as possible. And that has benefits and drawbacks. The benefit is it makes it very frictionless for pediatricians to refer. If we say we take pretty much everyone, right now, it's only in commercial for our fee-for-service business. It's commercial and Medicaid for collaborative care. The drawback, as you know, is they're very variable reimbursement rates from payer to payer.
Sure.
So, you've got some payer contracts that are going to be a little bit of a drag on your margin. Philosophically, though, we believe that is worth it because we're trying to make lives easier for pediatricians and families. Um, right out the gate, what we were trying to prove is we had a theory, and this was really informed by my time at Anthem, which is now Elevance, that healthcare is super local. It's super relationship driven. Innovation happens locally with the health systems, with the provider groups, etc. And the easiest way for us to get the flywheel going is deeply saturate a market. So that's why we started with New Jersey. We now have 1 in 3 pediatricians in New Jersey have referred to us, which is great. And we decided not to do a national model because of the administrative overhead and complexity of maintaining all of those legal entities, cross-licensure, et cetera, et cetera, et cetera, filing taxes. I mean, it seems like a little thing, but you compound all of that work. So that bit has paid off, and that will continue to be our strategy to do a slower market expansion, but to go really, really, really deep in each of those markets.
So, what does it take to staff out any one of those? So, if you're relatively close to maturity in New Jersey, for example, what number of, how big a medical group do you need there? What's the composition of it? What are they doing? Give me a sense about what does Ford Health at scale any one market look like?
That's a great question and a complicated one to answer because the caseloads are so different between collaborative care and fee-for-service. Collaborative care, for example, you're looking at between sort of 70 to 85 patients in a caseload. It's a much more efficient model. Um, with fee-for-service therapy, you're really looking at a considerably smaller caseload, especially with kids, because kids are in school all day. You can see kids from sort of 3:30 to 8:30 onwards. But in terms of licensure types, it is licensed social workers, LCSWs, a handful of psychologists, psychiatrists, psychiatric nurse practitioners. That is our primary mix. Um, we do not staff with unlicensed therapists, just because we're relatively small, and one of our sort of focuses and priorities is how do we maintain consistency, right? And it's probably an imperfect analogy, but if we want to be Starbucks, that if you order a Frappuccino, it doesn't matter if it's from your local corner store here or one in New York, like it's getting made the same way. Our clinical pathways are the same. Like there is a consistency in our care and how we do our training, etc., which is much sort of easier to do with a more contained set of licensure types.
And so I suspect that means you can have a relatively small number of clinical professionals in any one state. Does that sound about right? I don't know I'm trying to, what I'm trying to get at is, two things. One is, can you easily scale, if you get saturation in the market and then do this market by market approach, or state by state approach, is it relatively easy for you to grow the medical group that you're
Yeah.
creating in each of those states? Because that seems to be a significant problem with a lot of online therapy, not so much online mental health, not just in kids, but in general. It's like, you hire therapists, they don't stay around a long time. There's a lot of turnover, and then there ends up being problems with the quality of the care. So I'm going kind of trying to figure out how you're thinking. I assume that this is one of the major problems you have. If you tell me this is easy and you want to tell me the other problems, that's great. But I suspect this is a big issue for you.
Yeah. I'm glad you raised that because I think that's a common misconception. Um, there are providers out there and they are hireable, and we are actually ahead of our hiring targets. And because we have a mix of part-time W-2 workers and 1099s, just about everyone has gone to the 1099 model. So I think our staffing model is probably fairly common. Um, that is not the primary issue. I think one of the challenges is that in tech-enabled services, there are sort of always two pressure points. And the one pressure point is reimbursement rates, and the other one is labor costs. And over the last several years, as mental health care services have become more prevalent, demand is up. That has put extraordinary pressure on supply. So we've seen sort of wages inflate over time, and they have not been commensurate with reimbursement rates. So I think that is a challenge for the whole industry. And in fact, if you look way back, sort of reimbursement rates, from 2007 to about 2017 for mental health services were sort of declining year over year. So, I think that is a challenge because if the problem we are trying to solve is mental health care for kids, let's just start with that. The way in which we're seeing it get addressed is through things like, well, let's just stop social media, right? There are now like 12 states that are requiring parental consent for social media, et cetera. And it feels like a very convenient way to improve youth mental health. But some of the real problems that we're not addressing is how do we attract more people into the field? Number one, how do we make state licensure less onerous? How do we make payer credentialing much more efficient? Those are the things that are really impacting supply that are less sexy and interesting, and people aren't really talking about it as much as they're talking about social media. Those are some of the real problems. And, Matthew, to go back to your original question about supply we can manage, right? We can control with our brand, with how much we pay. Some of the pieces we can't control is how long it takes to get licensed in a particular state, how long a payer takes to credential, etc. Those worry me more because they are out of my control as a founding CEO.
All right. So tell me now let's go back to the for health as a business, right? So yes, compressed margins. You're buying it, you're selling at one price and buying at another, and that those two may be uncomfortably close together. You have to build up a connection with the pediatricians based on your model, which sounds like a very clever model, but requires obviously sort of boots on the ground and getting to people to know you in each one particular marketplace. So when you walk into an investor's office and say, I'm going to build out this big venture backable business, what are you telling them as to how you're going to grow it to being, the kind of thing that they're going to cash their chips and go sit on their yacht for, given these problems you just mentioned.
Yeah.
I'm sure you had these conversations when you were raising money last year, right? Something on or something similar.
One of the aspects of the business that, when you start a startup and you place bets, you're never entirely sure which ones are going to materialize and where you're going to need to pivot. So it's sort of use your best judgment and make a few strategic decisions and then let a few months play out. Okay. So we got really lucky because a number of the strategic bets we made upfront have materialized. So we haven't had to pivot. We've maybe refined some of our thinking. One of those was our go-to-market. And it was really, honestly, that discussion I had with the pediatrician that made me start thinking like we can solve two problems at once. One with the pediatrician that their phones are ringing off the hook and parents are calling and they don't have the resources, to send these kids to other people. And how do we solve for that? And if we do it really elegantly, that's going to solve a problem for the parents as well. They're not going to be handed that sheet of paper. So we went all in on that. And we now have, the fact is we have like 850 salespeople in market. And these are the pediatricians that are actively endorsing us, actively promoting us, actively referring to us, even innovating. The sort of little ideas that these pediatricians have come up with are really quite remarkable because they're thinking about every single day, how can Ford Health shave off a few more minutes, right, of my office's time by doing this more efficiently. So they really have been amazing partners. And we avoided the very costly DTC model. We avoided the complicated employer model, which, as you know, you have to go through HR benefits manager. You have to be large and interesting enough, and you have to significantly impact utilization or ER visits to be able to substantiate that you can reduce claims costs. And then schools, well, there's definitely a place for school support. There are some concerns with that model as well, because you're always subject to sort of school district budgets. And it's also limited in terms of how much care you can offer these kids. It's somewhat rationed. So our go-to-market has been very elegant and repeatable. That said, we have found New York's very different to New Jersey. We're just entered into Texas, which is completely different. So we have a deep appreciation for sort of the nuances in each state. So that's how we scale. We have a phenomenal sales team, a really good sales playbook that's repeatable. And then on the clinical side, what we're really proud about is we focused a lot on clinical quality upfront. And that was through our partnership with the Child Mind Institute, they're sort of the leading, they kind of the gold standard in the nonprofit space. They are based in New York, so we have an exclusive partnership with them. And that was the training, the clinical consultation, et cetera, to really get us off the starting block much faster than we would have if we were operating on our own. Um, so that focus on clinical quality and then being able to take gold standard clinical outcomes to not only the pediatricians, but also be able to showcase those to hospital systems and provider groups that we now have partnerships with, really helped accelerate our progress.
All right. So the key is that you figured out a way to sell it cheaper. To be grass and by making these alliances by the pediatricians and
Yeah.
and you're not necessarily subject to some of the other types of metrics that maybe are tripping up some of the competitors who do some different who've gone in a different direction. Very interesting. So let me ask you the final question. You may or may not share this with your board or your investors, but you can tell me and tell the world. What does good look like for Fort Health? If you play this out 5 years, how many markets are you in? I assume there's almost a limitless amount of demand from the kids and pediatricians, but how many markets are you in? How big do you get? What does good look like in the end of your 5 year plan?
Um, Good looks like us, as some of these things are going to be softer, but good looks like we have not compromised on our clinical philosophy. I don't wake up every morning to just be a matching platform. Um, so we continue to be a leading employer of choice and a place that therapists really want to work. We're enriching them, we're training them, etc. In terms of through an investor lens, what it looks like, we don't have a specific number of states. It is really about at what point do we reach saturation in a market? And a little bit of that right now is driven by the percentage of the Medicaid panel for each of those pediatricians. In future, that is our aspiration to be in Medicaid. We're primarily just in commercial right now. So once we sort of hit a ceiling in each of those markets, we'll move to another market. Um, but, in 5 years' time, I think that starts to open up some interesting windows for partnerships, possibly acquisitions, et cetera. At that point, it's fully proven. You've got a model that's highly scalable, and really the only thing standing in the way is capital.
Yeah, I mean, I think this has been sort of one of the interesting things about all of the different startup is the wrong word, but new types of medical groups that I've been talking about and talking with over the last few years is, how do you figure out we've had a traditional system where medical groups are either allied to a hospital because they are doing some service, usually trying to stick more referrals into it so the hospitals can make money, or they're now part of some big conglomerate or insurance company like an Optum or what have you. I guess, the question is it possible to build an online medical group, in this case for child and pediatric behavioral health, that can replicate itself in multiple different states, and be profitable enough that a venture capitalist will be interested in the return it's going to deliver. And, to me, if you look at what's gone on in some of the physical sort of for-profit medical groups, the news isn't always great, right? And so I think it's a real challenge. On the other hand, and this has been, where I think it's very interesting, where you have something which is not dealt with well in the sort of real physical world, and I mean, access to psychiatric and mental health care for kids is a great example, but there are many others. You know, why can't we use technology to come up with a different approach that should allow you to scale this in a better way that enables you to both, do good and actually do well. And I guess that's the challenge you're going to be riding for the next several years. So, perhaps you shouldn't have gone on that walk with a pediatrician. You might have found an easier life.
Yeah, I'm highly confident in our ability to scale. We can sort of squint and see paths to profitability. And you do need to get to that sort of critical mass so that your investments in technology, which we've built out a lot of our own proprietary tech, um, begin to pay off. So I look forward to having this conversation with you again in a few years, and we'll have more to share. But thank you for letting me share a little more about Fort Health and some of the problems we're trying to solve.
Fantastic. All right, I've been talking with Natalie Schneider. She is the CEO of Fort Health, a relatively new player in the pediatric and the pediatric and child. Pediatric is child, I guess. Behavioral and mental health area. Natalie, thanks for your time.
Thank you. Take care.